Welcome to the Adelphi, New York statewide breast cancer hotline and support program's STEP program video series. I'm Dr. Clarissa Bonanno, and I'll be discussing breast cancer and pregnancy. As an overview, a diagnosis of breast cancer during pregnancy is an incredibly challenging situation. Therefore, we need a cohesive, multidisciplinary approach to treatment. But in many cases, optimal outcomes for the patient, the pregnancy, and the fetus are possible. What is pregnancy-associated breast cancer? Well, by definition, breast cancer diagnosed during pregnancy or in the first postpartum year. But for the purpose of this talk, we're going to be focusing mostly on breast cancer during pregnancy itself. Breast cancer is the most common type of cancer diagnosed during pregnancy, and it occurs in approximately 1 out of every 3,000 pregnancies. Unfortunately, the incidence of pregnancy-associated breast cancer appears to be increasing in the United States and is predicted to continue to increase. What are the breast changes and important points on breast care during pregnancy? Breast symptoms and physical changes are very common during normal pregnancy. Unfortunately, the diagnosis of pregnancy-associated breast cancer can be more challenging, and this can be in part due to pregnancy-related changes in the breast, including an increase in breast density and nodularity. And in addition, most pregnant patients are younger than 40 years old, and therefore they are not candidates in most cases for routine breast cancer screening. It's important to know that during standard prenatal care, patients should have a clinical breast exam, and this typically occurs at the initial prenatal visit. In addition, patients should discuss any breast concerns they have with their obstetric provider. What diagnostic tools do we have in pregnancy? Well, importantly, the evaluation of a breast mass should not be delayed due to pregnancy. Ultrasound and mammography are the most utilized imaging techniques to evaluate breast masses in general and also during pregnancy. We do want to minimize ionizing radiation exposure in pregnancy for fetal health. In addition, we do avoid use of magnetic resonance imaging, or MRI, with contrast, which refers to the use of gadolinium, again for the purposes of fetal health. But in certain situations, MRI with contrast can be used if absolutely needed. In addition, breast biopsies can be safely performed in pregnancy with the use of local anesthetic agents. The most common histology of pregnancy-associated breast cancer is invasive ductal carcinoma, similar to the most common histology in general for breast cancer. However, pregnant patients are more likely to have estrogen receptor and progesterone receptor negative tumors compared to those who have never been pregnant. A detailed staging evaluation of how far their cancer has progressed should be performed during pregnancy, and this workup should be individualized and tailored to minimize fetal radiation exposure. Unfortunately, pregnant patients, largely due to the factors I mentioned earlier, are more commonly diagnosed with breast cancer at more advanced stages. We're going to go over, in general, some principles of breast cancer treatment during pregnancy. So treatment of pregnancy-associated breast cancer should adhere to standard treatment guidelines whenever possible. When pregnant patients are treated with standard cancer protocols, pregnancy does not affect the patient's long-term prognosis. However, treatment should always be individualized according to tumor characteristics and their stage of cancer, the gestational age at diagnosis, as well as the individual perspectives of the patient and family. It's important to know that in most cases, pregnancy termination will not improve the patient's outcome. Surgery is one of the first-line treatments for many patients with pregnancy-associated breast cancer. Surgery can be performed in any trimester of pregnancy when necessary. The second trimester is the ideal time to have surgery, but it is not mandatory. Either mastectomy or breast-conserving surgery can be performed as indicated. In addition, sentinel lymph node biopsy can be performed provided that the material used is technetium-based. Breast reconstruction is typically delayed until after pregnancy. Indications for chemotherapy for pregnancy-associated breast cancer are the same as for the non-pregnant patient. Anthracyclines, cyclophosphamide, taxanes, and carboplatin are the preferred agents for use during pregnancy. Chemotherapy can be administered in the second or third trimesters of pregnancy. However, chemotherapy is not recommended to be administered after 35 weeks gestation or within 3 weeks of a planned delivery to allow the patient, as well as the fetus, to have bone marrow recovery. In addition, chemotherapy dosing should not be altered, either increased or decreased, due to pregnancy and should be administered in a standard fashion. Many adjunctive therapies for chemotherapy-related side effects can be used safely in pregnancy. Steroids, often used for chemotherapy-associated nausea, are preferred if they are metabolized by the placenta. This means using non-fluorinated steroids to avoid exposure of the medication to the fetal system. Again, is chemotherapy safe in pregnancy and safe in the long term for the eventual child? In fact, yes. Long-term studies on children exposed to chemotherapy in utero show very favorable medical as well as developmental outcomes, again referring to exposure in the second and third trimesters only. Prematurity actually has a greater adverse impact on child development. Therefore, a preterm delivery should be avoided when at all possible. There are some risks associated with chemotherapy exposure. Fetal growth restriction, so having a fetus that is growing smaller than expected during pregnancy, is more common in patients receiving chemotherapy. In addition, spontaneous preterm birth is more common in patients receiving chemotherapy than those that are not. There are many breast cancer treatments that are generally reserved for the postpartum period because they are either not safe during pregnancy or we don't have enough evidence to prove that they are safe for the pregnancy and the fetus. These include, in most but not all cases, radiation therapy, targeted therapy such as trastuzumab for HER2-positive breast cancer, other targeted immunotherapy agents, and hormone therapy with tamoxifen or other selective estrogen receptor modulators. In terms of breastfeeding, those who have had bilateral mastectomies can feed their newborns with formula or in some cases with donor breast milk. Those who have had unilateral mastectomy or breast-conserving surgery can consider breastfeeding if they wish. Those who have had previous breast radiation may not produce milk from the affected breast. In those cases, unilateral breastfeeding can be considered if the patient desires. Patients should delay breastfeeding at least 3 weeks after receiving chemotherapy to minimize exposure of the medication to the breastfeeding infant. Psychological support is an integral part of the care for patients and families experiencing a diagnosis of cancer in pregnancy. Patients may need additional support postpartum when they are going through a diagnosis such as cancer, in addition to all the risk factors for postpartum mood disorders. So, what specifically happens after a diagnosis of pregnancy-related breast cancer? Well, first, patients should have a consultation with medical oncology as well as surgical oncology to develop the best treatment plan for their specific case. Many patients will be referred to genetic counselors or have genetic testing as indicated to see if they have a genetic disorder underlying their condition, and also to know if they have a genetic disorder that could be passed on to their children. In addition, patients will have a consultation with maternal fetal medicine. These are the high risk obstetricians to discuss implications of the diagnosis or the treatment plan for their pregnancy and fetus. How do we follow patients with pregnancy related breast cancer? Well, for the maternal side, we're going to continue monitoring for and managing any side effects of their cancer treatment. We'll closely monitor maternal weight gain as well as nutrition. In terms of the pregnancy, we need to continue their standard prenatal care as well as monitor for any signs or symptoms of preterm labor. In terms of the fetus, we'll be doing regular ultrasounds for fetal growth and well being, and we'll have many discussions to optimize the timing as well as circumstances of delivery. For those patients who are considering pregnancy after a breast cancer diagnosis, we recommend deferring pregnancy for 1 to 2 years after a cancer diagnosis. Those patients who have had early stage breast cancer, which has been optimally treated, future pregnancy does not increase their risk of recurrence. In addition, for those with early stage hormone positive breast cancer who require prophylaxis with tamoxifen, pausing that therapy after 18 to 24 months of treatment to allow them to conceive has been shown to be safe in the short term. The whole care team should address both contraception options as well as the patient's reproductive plans and fertility preservation options when they are formulating a plan for treatment. We have a unique center at Northwell Health dedicated to the care of pregnant patients with cancer and patients with cancer who are considering pregnancy in the future. Our center provides individualized, multidisciplinary care for patients with a diagnosis of cancer in pregnancy. In addition, we provide preconceptional counseling for patients with a history of cancer who are considering pregnancy and want to discuss the impact that diagnosis may have on their care. We also provide fertility counseling and offer fertility preservation options for patients with a diagnosis of cancer. We have an excellent nurse navigator who is provided to our patients to help coordinate their care and to support patients through their journeys with us. We've listed here resources for patients and families. The Northwell Center for Cancer, Pregnancy, and Reproduction is available at the telephone number here. The Adelphi Breast Cancer Hotline and Support Program also has licensed social workers available for patients with this diagnosis. And finally, Hope for Two is an association that connects women diagnosed with cancer during pregnancy with others who have navigated the exact same diagnosis during pregnancy and can provide unique support. Thank you for joining us. We hope you enjoyed the STEP program video series. For more information, visit us online.